Okay. Hi. Amazing. Okay. So I think we stopped last time around finishing. No? Yep, finishing polymorphous and curviform polymorphous. Does that ring a bell? Okay. So we'll move on to acidic. So acidic is one of those things where sort of most of the time it's obvious because the cells will look like just normal serous acinar cells of the parotid. So mostly these are in parotid gland. Mostly they're low grade, but they can undergo high grade transformation, just like all of the other salivary gland tumors we've seen. Basically, right, it's just sheets of serous acinar cells without any ducts, without any fat, without any intervening anything to let you know that this is like normal parotid tissue. Sometimes there's lymphoid stroma around the periphery, so that's completely acceptable. If you want to prove, right, that they are acinar cells, the zymogen granules are PAS positive diastase resistant. There are some immunostains that can help you differentiate between acidic and its mimics, but we can get into that at the end where I have like a table of all the immunos. And recently, mostly these have NR4A3 gene fusions. So, you know, we're learning more about molecular salivary, and this is no exception. Lesser gene rearrangements include this MSAN-D3 gene, but in case these pop up on your studies or your boards or whatever. So here's an example of low-grade acidic cell carcinoma, normal parotid on the left, tumor on the right, and then here's your diastase-resistant zymogen granules. If you can see the zymogen granules on H&E, I don't usually use this, but it can be helpful in cases of high-grade transformation or so-called dedifferentiation, right? So when we think about, when you read about salivary gland dedifferentiation or salivary gland high-grade transformation, remember that pretty much any tumor can undergo it. Pretty much any tumor ends up looking just like sheets of an undifferentiated epithelioid high-grade malignancy, right, with mitoses, often with prominent nucleoli. You know, other things you of course look for are going to be like PNI, LBI, et cetera, right? But sometimes you cannot tell what the tumor is unless you have molecular or you have a pre-existing kind of lower grade area. And so on the right, you have these sort of small acinar-like structures in which focally you might be able to prove that there are zymogen granules, and you can call this a dediffacitic. But sometimes it can be very hard. And this is really critical, right? Because these patients have much worse prognosis. They will get neck dissection, they'll undergo chemoradiotherapy often. Sometimes they can also get distant metastases to, you know, bone, et cetera. But that's what things you want to be looking for. I put secretory next to acidic because secretory carcinoma was described kind of out of what used to be thought of the microcystic variant of acidic cell carcinoma, right? So if you look, sometimes acidic cell carcinoma has these small, like acini, right, or microcysts. And there were zymogen poor microcystic variants of acidic. There still are, but they very, very histologically mimic what we now know is a completely different entity, which is secretory carcinoma. And these were described in 2010 due to resemblance to secretory carcinoma of breast, usually which was in kids, in pediatric patients. They have the same immunoprofile, the same molecular, which is ETV6 and TRAC3 fusion. You can see this in the major and minor salivary glands. Again, mostly low grade, but some have high grade transformation. And so what they look like is a variety of histologic patterns. You can see anything from small cysts with secretory material to larger cysts to even these like little papillary-like structures. And so on the next slide is kind of the variety of morphologies, but the common denominator is there's generally some kind of material, right? Whether it be this pale stuff in the lumen that almost kind of looks like milky or like serous-y, these vacuoles in the cytoplasm of the cells. And So it's these that used to be called the microcystic variant of acidic. But the ones that have the translocation, right, are now secretory. What's unique about them is that they do not have any zymogen granules in their cytoplasm. If you were to stain them, the secretory material stains with PAS, but not anything in the cytoplasm. And they are diffusely positive for S100 as well as mammoglobin. So these two stains in combination are really useful to make this diagnosis. What high-grade transformation looks like is kind of like other tumors, where you start to have sheets of cells with prominent nucleoli with necrosis. So you can see in this low-grade thing on top a transition from more of a kind of patterned secretory area to this more solid, very infiltrative area on the right. So again, things to look out for. Questions?
So how do we tell them from a mesh from?
You can't because they're identical. But it's been discovered now that this is actually thought to be more commonly primarily arising in the salivary glands than in the breast. So in 10 years, I've seen one example of breast cancer metastatic to the salivary gland, so it can happen. But usually if you see something, especially if it's low grade, it's gonna be primary, right? Because usually if it's a breast cancer, it's generally gonna be high grade. What?
ER stuff.
Yeah, and these are ERPR negative. So I honestly don't know the ERPR status of the juvenile secretory breast cancer. If someone can find that out, that'd be great. But I do know that all salivary carcinomas should uniformly be ERPR negative or extremely, extremely weak and like non-specific. If you see any ER or PR significant expression in a salivary tumor, think about a metastasis. Salivary duct is very similar to high-grade DCIS. The difference being that as opposed to these large nests, right, large nests with like comedotech necrosis, instead of these being intraductal, these are invasive, right? So you will not see a P63 or P40 positive layer around these, but on low power, they can sort of resemble DCIS. So salivary ducts can either be de novo, but often can arise out of a pleomorphic adenoma. So we often see carcinoma X morphologically appearing as salivary duct. These are uniformly high grade. They have this apocrine morphology, very frequently PNI and LVI, and strong nuclear androgen receptor positivity, and often very strong membranous HER2. We've shown that those that are HER2 like 3+ do have HER2 gene amplification. So not only can this help you in diagnosis, but often treatment, right? So often in these high-grade salivary carcinomas, our clinicians are asking for AR and HER2, mostly to see if they can treat these, right, with androgen antagonists or Herceptin. But as I said before, ER/PR should not be accepted in these. So large nests with kind of cribiform structures with central necrosis. Sometimes, right, you can have small infiltrative pattern like this small nested or micropapillary pattern. And there's your example of your androgen receptor and your HER2. Genetically, these are not specific. They kind of have a myriad of mutations, including those in TP53, like P10, PI3K. So they don't have a disease-defining mutation, but they do have kind of a conglomerate of various genetics. There's this tumor that used to be thought of as low-grade salivary duct, or intraductal salivary duct, but it's somewhat kind of teased out right now. These you may read about this historically in the literature as low-grade cribiform cyst adenocarcinoma. That name is no longer used. We now call intraductal, because these are actually bounded by P63 positive myoepithelial cell layers. They kind of have similar kind of cribiformy spaces. they have these lumina. They have this micropapillary like proliferation into the architecture. But when you do your bioepithelial or basal cell marker, right, you'll see that it's actually intraductal. And here you can even see that on H&E. So as long as these remain within the duct system, they are basically biologically indolent without any metastatic potential. They can, however, invade out of the duct and also be invasive, right? But mostly they start as this. They are those cells are positive for things like S100, SOX10, and mammoglobin. So if you only have like tiny little biopsy or aspirate and you're seeing these cells, your differential might include another kind of S100 positive salivary carcinoma. But I'll talk about that when we get to the table. They have different genetics. They often have RET fusions. There is an apocrine subtype that also can resemble salivary duct. But these again are intraductal and sometimes have androgen receptor. So depending on the morphology and the immunoprofile, they are split into these subtypes, but these are pretty rare. But you may see these. Okay. And epimyoep. So this is another one. In addition to, what else did we talk about? Adenoid cystic, right? In which the epithelial and the myoepithelial cell components are part of the tumor, right? So rather than this one, right, in which it's thought that the myoeps are benign, not bystanders. In this case, whoops, wrong way. In this case, both of these cell types are neoplastic. And so epimyoep, you want to be able to see inner kind of luminal epithelial cell layers, outer myoepithelial cell layers that are often clear, often very prominent myoepithelial cell layer, as opposed to those flattened kind of compressed ones, right? And sometimes these ducts are focal. Sometimes you're just in a sheet-like background of myoepithelial cells, you focally see these ducts. And so you might ask, well, how is this different than like a pleomorphic adenoma or an adenoid cystic? It can sometimes be hard to differentiate. So sometimes people have used the presence of a RAS mutation as a disease-defining entity here, but there are clues. One, epimyoep often has this kind of lobulated growth pattern, very similar to what we see in pure myoepithelial carcinoma, often where this periphery of the lobules is more cellular and the center is more paucicellular, sometimes even necrotic. You don't want to see true like cartilage, right? Because that would be more of a PA type of picture. And as I said, often these ducts are just sort of punctuating these larger areas of background myoepithelial cells. So that's not uncommon. You want to look for things like, necrosis, mitoses, other features of, in either malignancy or high grade to help your diagnosis. It's not adenoid cystic, right? When we think about biphasic tumors, right? It's not adenoid cystic because usually the cells of adenoid cystic, the nuclei are much smaller and wrinklier, and the pattern is different, right? We don't really see cribriforming here. We don't really see that bluish basement membrane material so much. So hopefully that makes sense. I think there was I don't know who was on service, but there was something that looked like it was biphasic epithelial myoepithelial in the GYN tract like a few weeks ago. I don't know if anybody had that case, but Jenny did the molecular and like it didn't have the HRAS. So who knows if these morphologically salivary type tumors are identical to those that exist, in and outside of the salivary glands, but you can see salivary type tumors, right, in other organs. So just keep that in mind. Questions? Okay. Hyalinizing clear cell carcinoma. It's kind of exactly what it says. It is mostly composed of optically clear tumor cells, often with wrinkled nuclei, and has these hyalinizing bands that course through it. Usually this is not a major salivary gland. Usually this is a minor salivary gland. They stain like squamous. So high molecular weight keratin and 63p40. And so you might say, well, how do I differentiate this from a myoepithelial carcinoma, which could also be clear cell and also have high molecular weight keratin and P40? Well, they don't have any other myoepithelial markers. No SMA, calponin, S100, SOX10, nothing. So if it looks kind of myoepithelial-like, but lacks the myoepithelial specific markers, think about this, and then you can prove it if you need to with genetics, which is EWSR ATF rearrangement. There is a morphologically identical tumor in the jaws called clear cell adenogenic carcinoma. The only difference is that it arises in the jawbones instead of in the soft tissues up here, but is otherwise identical. So then when you think about squamous cell carcinoma, right, if you think about this can be immunohistochemically similar to squamous, well, it's different, one, because of the genetics, two, because it's usually low grade. These are usually very bland without lots of mitosis or necrosis, but when you have metastatic squamous cell carcinoma to salivary gland areas, usually these are frankly like high grade, keratinizing squamous cell carcinomas. If you see an actual squamous cell carcinoma in the parotid, your differential, right, is basically going to be a metastasis from someplace else. Because pure squamous cell carcinomas don't really exist primarily in the parotid. They are metastases from cutaneous primary scalp, right, to intraparotid lymph nodes, because the parotid is the level that first drains anything in the upper head, right? So you can prove it. We've often done this when we are uncertain, because maybe it's an old patient and they don't remember, like, oh, I don't know, maybe I had something burned off my scalp like 10 years ago, but I don't know, right? You can do NGS and prove that there's an ultraviolet signature mutation, right? So the C to T or the CC to TT base pair changes, which is the cosmic signature like 7, basically, for those of you who are interested in molecular, right? So if you can prove that it's a metastasis of a skin cancer, generally this is a better prognosis for the patient than a otherwise NOS high-grade salivary primary carcinoma, which tends to go to, metastasize to visceral sites, etc. On occasion, there are viral-associated tumors that you can find in the gland, in the parotid, sometimes that are either metastases from nasopharynx or oropharynx based on EBV and HPV expression. There used to be these reports of primary lymphoepithelial-like carcinomas of the salivary glands that have EBR. Whether or not those are primary, again, or mets, I'm not entirely sure. But usually, the parotid is not where the mucosal sites drain, right? Usually, the parotid, as I said, drains the skin, but the mucosal sites drain farther out to like mostly levels 2, 3, 4, sometimes level 1 submandibular, right? So depending on which glandular area you're in, your differential diagnosis may be slightly shifted depending on the patterns of lymphatic drainage. Does that all make sense? Okay. So at the end here, I have a couple summaries of your monomorphic tumors and your biphasic tumors to help us kind of sort these out, right? So as I mentioned, the biphasic tumors that have myoepithelial and / basal or epithelial cells, both in the tumor, are epimyoep, right? Are pleomorphic adenoma, are adenoid cystic, and are the basal cell neoplasms, right? The basal cell adenomas and the basal cell adenocarcinomas, which we already talked about. So you have 2 benign things, right? PA and BCA, and 3 malignant things: basal cell adenocarcinoma, adenoid cystic, and epimyoep. And I put the basal cell neoplasms here together because they are very, very morphologically overlapping. Oftentimes there are subtle morphologic differences as well as associated genetics that, if you need, right, can help you distinguish those. In cases where you cannot prove that there is a myoepithelial or a basal cell layer, and this is a monomorphic tumor, often these end up being, sorry, that's pale, often these end up being diffusely strongly S100 positive, right? So We talked about secretory having S100 and mammoglobin. We talked about polymorphous or cribiform having S100, but not so much mammoglobin. I think did I have canalicular adenoma in here? I think I did, right? But this is the one on the upper lip of like elderly females. Also S100 positive. Intraductal, right? S100 and mammoglobin, but bounded by that peripheral myoepithelial cell layer. And the only one, right, that's not S100 positive is acidic. All of these should uniformly be negative for P40, except for the peripheral myoepithelial cells and intraductal. Polymorphous is thought to like aberrantly sometimes express P63, which is why we don't really use P63. We always use P40 for salivary for that reason. Acidic sometimes has membranous expression of DOG1, right, like we use in GIST, so that can be sometimes helpful. I don't really use GATA3 because it's not very well studied, but can be positive in some salivary gland tumors and many salivary gland tumors, but very strongly it's thought in secretory. So, you know, I don't use it, but we've got other methods. But some people, you might see outside institutions throwing GATA3 on their salivary tumors. And then again, genetics to sort those out. I think this is kind of a duplicate because we already have that information up there. So I think, yeah, that's the end of the PowerPoint. You guys have specific questions? Okay. All right. In that case, let's go to some virtual slides, yeah? Do you want to look at, I have 3 different salivary things. One of them has like starts as core biopsies and then moves to the resection, and the others I think are just resections. Do you have a preference? Core biopsy? Okay, perfect. Okay. Whoops. I don't know what that is. Okay. We're gonna skip through that. We're gonna skip to the slide. So, right, just reminder, when you are dealing with a core, you only, most importantly, have to offer whether you think something is a low-grade salivary type neoplasm. You don't have to commit to benign or low-grade carcinoma because they will resect it with negative margins, or whether it's a high-grade thing. Or if you're concerned for adenoid cystic, right? Because with adenoid cystic, that's the only carcinoma that no matter whether it's sort of high-grade or low-grade morphologically, they may end up doing a neck dissection. Okay, so let's just start. Oh, if anyone's interested, tomorrow, yeah, Friday at noon, in the, I think we're gonna be in here. I'm gonna talk to the cyto group about salivary issues. So core biopsy, FNA, frozen. And so sort of how to sort out the thinking on that. So if anybody wants, here at noon tomorrow. Okay. All right, so here's a core biopsy of, let's see if we can tell where we are, right? Where do you think we are? Parotid, because we're all serous, okay. And then we have a neoplasm that has predominantly myxoid stroma with small gland looking cells in it, very fine chromatin, right? No nucleoli. Maybe you can make out, maybe there's a duct punctuating here and there. Yeah, maybe there's a duct here and there. So if all things considered, what is an adequate diagnosis in this case? Based on what I just said. What? Yeah, low-grade salivary neoplasm, right? If you had no other information, low-grade salivary neoplasm, right? It looks salivary in morphology, you don't see anything high grade, they will resect it. If you wanna go further and you wanna prove that this is biphasic, right? You can prove epithelial and myoepithelial cells, and you can prove that it's a low-grade biphasic salivary neoplasm. But you don't have to. And so this is the resection, which was a very small what? If anybody else wants to drive, feel free to come up here and drive, because otherwise I'll just be talking the whole time. So very mixoid background, right? Small gland cells within the mixoid background. Occasionally we have maybe these ducts. So what's your diagnosis? Circumscribed. Huh? Low-grade mucoep? Well, in order to diagnose mucoep, we need to see intra-cytoplasmic mucin, not just stromal mucin. So do we necessarily think we see intra-cytoplasmic mucin? You can do a mucin stain or a PAS diastase to help you out with that, but let's say there is none.
Secretory?
What?
Secretory?
Secretory?
Oh, secretory?
Oh, okay, so what in this case is present that you might not expect for that diagnosis for secretory?
Stromal.
Yeah, the stroma, so this is a little too much stroma, and arguably too many like small solid-ish areas, right? So you really wanna see mostly cysts and ducts, as opposed to, in this case, only occasional sort of ducts, right? Duct. Solid. All right, am I making this too hard? Somebody tell me what this is. What? Pleomorphic adenoma. It's just a pleomorphic adenoma, right? So it's just a pleomorphic adenoma that is mixoid rich, that has only occasional ducts, right? But it has a lot of these background kind of spindly myoepithelial cells, right? But so this is a pleomorphic adenoma. Okay, I wasn't trying to make that difficult. Okay. Next core. We don't really need the full. Okay.
Still low grade.
Still looks low grade. Most important thing, maybe there's a duct. Sorry, somebody said something. This thing makes it really hard for me to hear. Okay, so you think about epimyoweb, because if you think that they're focally punctuated by ducts, absolutely, where you have kind of a background of maybe more sheet-like myoepithelial cells, okay. Yep, so if you wanna prove, right, that it's biphasic, maybe we can throw some stains on there. But what biphasic tumors does it really not look like? What's the most important biphasic tumor to exclude? Adenoid cystic, right? Because if we think it's adenoid cystic, they may treat it differently, more aggressively, okay? So it doesn't really look like that characteristic adenoid cystic pattern with wrinkled nuclei, with criboformine, okay? So we've kind of knocked that out, but we could think of something else biphasic, right? Like an epimyoweb, like a PA, or something monophasic, if we can't prove that those are ducts, right? So you could think about a monophasic neoplasm. So did we do stains? Yeah, we did. So this looks like it's staining the epithelium of a tonsil. So this must be like a, yeah, P63 or P40. So, so we have many cells that are staining, but we have some that are not, right? So the thing that I am very critical about in interpretation and reporting of salivary gland immunohistochemical stains, which I sometimes see poorly done from consulting institutions, is just to say that this is like P63 or P40 positive. Well, yes, but you really have to subtly notice whether there is any negative cell population, and if that negative cell population is architecturally or structurally different, right? So you may perceive that there are these vague, small rosettes or duct-like structures of negative cells, right? So that's critical. That's critical when you're thinking about, is this a monophasic or a biphasic neoplasm? And so I would say yes, most of these cells are myoepithelial and P63/P40 positive, but there are negative vague duct-like structures, right? There are negative vague cells that may be here's a nice example, right? That may be an epithelial component. And probably this is, okay, these are mast cells. So this is probably my second stain that I use, right, which is c-Kit. So P40 and c-Kit are the top two things that I always throw on, because c-Kit will not only stain the epithelial cells of adenoid cystic, it will also stain the epithelial cells of all of the other biphasic neoplasms. So it won't differentiate adenoid cystic for you. You'll do that on morphology, but it will differentiate monophasic from biphasic, right? So you can confirm that those P40, P63 negative cells you were seeing probably actually are epithelial cells, right? So just based on their amount, it kind of is the opposite, right, of the P63, P40. So we now have a biphasic thing. So it could be epimyo-ep, and it still could be a cellular pleomorphic adenoma, right? Because we don't have the edge. We don't know if it's invasive or not, but we do know that it's biphasic, and we do know that it's low grade. So low grade biphasic salivary neoplasm. I think we probably did, yep, an S1, there are your dendritic cells, right? So we did an S100 because that's the third most common stain that I throw on. Because if it's not biphasic, it's probably one of those monophasic S100 positive ones. And S100 is kind of non-specific. If you see some S100 expression in these sheets of cells, that's okay, right? Because they're myoepithelial, and we know that myoepithelial cells can express S100. So that's fine. It's fine for this tumor to have patchy S100 in the myoepithelial cell component. So here's the resection. Pretty circumscribed border with maybe a little bit of a pooch, but not a significant pooch at the edge. Now we have areas that we didn't see on biopsy, right? That look pretty much like what we saw in the immediately prior tumor. But most of it, right, most of it is this really, really, really cellular, but cytologically bland thing. So of our biphasics, which one is this?
Pleomorphic adenoma.
And I'm not trying to trick you. Yeah, this is just a cellular pleomorphic adenoma. Exactly. So don't be fooled by the rich cellularity. Some people call these cellular. Some people call them myoepithelial rich because that's what they are. But in that case, right, we allow a little bit of undulation of the borders of a pleomorphic adenoma, right, because these can have so-called pseudopods, right? And that nice mixochondroid matrix is very, very helpful. The biphasicness is very helpful, and the pseudopods are allowed. Okay. Another core biopsy. With myxoid matrix, with kind of spindly to plump epithelioid cells. Maybe there's a little lumina type of structure forming here and there. There's one there. There's one there. What is a little bit different, maybe I would argue, in some of these ducts is the kind of, I don't know, prominence of the bilayered. Maybe the nuclei are a little bit wrinkly and dark. But I think, at least based on this, based on the H&E, right, our differential is probably within the same realm, right? We think morphologically that there might be two cell types just based on H&E. So we can again prove it. So here's our nuclear marker, right? So our P40 showing many cells positive with ductal lining cells negative. So as we expect. Here's our C-kit, right? With your small, kind of tightly clustered epithelial cells being positive. So looks like it's matching the biphasic picture. This must be probably again S100. I don't see much going on. So, yeah, none of these are important. All right, so I'll cut to the chase and show you the resection because there are subtle clues on the core biopsy that I think will help us on the diagnosis, but the definitive answer comes in the resection. So did anybody have a preference between pleomorphic adenoma? Why not?
Okay.
What? Okay, so it's mixoid but not really chondroid, okay. And you said no? Yeah.
At least at low power, it looks kind of infiltrated.
Yeah, exactly. So, then we're down to maybe an epimyoep, right, or an adenoid cystic. Favorite thoughts based on what you saw in the core?
I don't really see crib forming, which I know is, you don't necessarily need to see on a core, but makes me question where it's at. Epimyoep.
Okay, so let's look, and sometimes, right, sometimes core can be deceptive. So here are arguably small cribiform structures. But I agree, right, that infiltrate on either side of this nerve, and maybe here are more characteristic, right, multi-punctate cribiforms. Don't forget that adenoid cystic has three major architectural patterns. One is cribiform. The other is tubular, right? So literally just bilayered tubules, right? Without having cribiform structure. So things like, right? Things like this or this that are just tubules, and solid, right? So maybe things like this that are just solid. So always keep in mind that you can have a tubular predominant, a solid predominant, a cribiform predominant adenoid cystic, and then one like this that has kind of garbage of all three. So based on this, would you agree with our diagnosis of adenoid cystic? Yeah. So if you go back to the core H&E, I think there are, not clear cut diagnostic features, but if you are uncertain, right, if you're uncertain that this is a biphasic pleomorphic adenoma, and you start to see things like this, those in and of themselves should at least make you think about an adenoid cystic, right? And in this case, one can offer molecular testing if it's going to change the surgery. And there are some cases where we have done this in order to prove whether it's adenoid cystic or not, to guide further therapeutic management. So if there's any inkling on your differential, you can offer the molecular if it's gonna matter. So that's the subtle features on this biopsy, yeah.
Like conversely, on a epi-myo-F, if you're in that kind of territory, like how often would you see performing? How often would you see like tubular? Cause I know they can do solid, but
Yeah, so tubular, yes, cribiforming, not really so
Okay.
much.
yeah, 'cause that's kind of, I thought was like the distinguishing thing, if you saw it clearly on a biopsy.
Yeah. Yeah, so the two tumors where you can have cribiforming, that are biphasic are of course adenoid cystic, and you can sometimes see cribiform areas in pleomorphic adenoma. Epimyoep, usually not so much. Polymorphous cribiform, right, could have cribiform areas, but that's monophasic, and that's, you know, you won't see a myoepithelial cell layer in the cribiform area, so you can write that off right away.
How can I tell in the biopsy that it's high grade or we
No,
can't?
you can't. So that's the problem with adenoid cystic is because grade is not reliant on morphology. So adenoid cystic technically, if you read the literature, is divided into 3 grades. Low grade, which is predominantly tubular, intermediate grade, which is predominantly cribiform, and high grade, which is predominantly solid. However, all of those should still have gland nuclei and low mitoses, right? There is a dedifferentiated or a high, quote unquote, high grade transformation of adenoid cystic where solid, necrosis, mitoses, nucleoli, right? That you can tell. If we saw that, you could say that, right? Even if you couldn't tell it was adenoid cystic, you could say this looks high grade, it has prominent nucleoli, mitoses, necrosis, right? But within the 3 conventional adenoid cystic grades, the tubular, the cribiform, and the solid, it's less clear how important those are for actual clinical behavior because all adenoid cystics, even within those 3 conventional grades, have lots of PNI, right? Have the potential to metastasize even aside from being fully high grade transformed. So that's why of all the salivary gland neoplasms, adenoid cystic is the one where like the conventional grading system is less useful. Because they will more likely treat aggressively, no matter what you call it, tubular or cribiform or solid, right? If you then call it high grade transformation, that's when they may add on things like chemo or radiation. Whereas if it's a conventional one of the 3 low grades, they may still, 3 conventional grades, they may still do wider margins with a neck dissection, but depending on the final, they may or may not give the adjuvant chemo and the adjuvant radiation. So that's kind of like the subtlety between those conventional grades and full on high grade. Does that make sense? Adenoid cystic is like the weirdo of all of these, right? It's just weird. And so tomorrow I'm gonna be talking about in this cyto thing, like on core biopsy or on FNA, when something is a basaloid neoplasm, right? And the differential is adenoid cystic, cellular PA, basal cell neoplasm. Those are the ones that adenoid cystic is actually a problem. And frozen can sometimes be useful, right? But if you call something a low-grade salivary neoplasm that's non-basaloid, usually it ends up being like a PA, a low-grade muco-ep, right? Something that is actually not a problem. But it's this so-called basaloid morphology, like this, that gets to be tricky. Okay, so yeah, so that's adenoid cystic. And so if you wanted to prove it, we've done our immunostains again, but the tissue here is a little bit not cooperating, so maybe we'll just skip the immunostains. Okay. All right, next. What time is it? 8:45. Okay, good. So carotid. Very cellular. Now we have these almost globular like balls. which we haven't seen yet. Still very cellular. We have some intervening, like, again, pale stromal bands. Basal cell neoplasm, yeah, so that, when I see these stromal bands and these stromal balls, a basal cell neoplasm is very, very high on my differential. And as we talked about, right, what's the best way to tell between basal cell adenoma and basal cell adenocarcinoma? Margins, indation, right? There are some features that might make you think about basal cell adenoma over basal cell adenocarcinoma. And the only thing is that basal cell adenomas are thought to have which mutation? That doesn't exist in basal cell adenocarcinomas. Beta-catenin, all right? So basal cell adenomas have beta-catenin mutation. Basal cell adenocarcinomas generally do not. So if you can prove nuclear beta-catenin expression, you are more likely, right, more likely to be a basal cell adenoma than a basal cell adenocarcinoma, even in the absence of that peripheral border. All right, so let's look at our immunostains that we know and love, right? So we're gonna look at the same ones. We're gonna look at P40, which highlights our peripheral myoepithelial cell layer, right? And our negative, right? Our negative ductal or epithelial cell layer. So that fits with biphasic, right? We're gonna do a c-kit, which shows nice more staining, right, in those luminal epithelioid cells, right? So that fits with biphasic, with the background basal cells being negative. We're gonna do an S100. And so in this case, right, S100 is helpful for a different reason. S100 is helpful because it strongly highlights the spindle cell stroma, right, in the basal cell adenoma that you may not have seen strongly on H&E. So when you look at these, you say, well, what's staining? It's neither the epithelial cells nor the myoepithelial cells. It's the background intervening spindle stroma between these epimyoepithelial islands. And beta-catenin, you can see, has nice, very strong cytoplasmic, but also nuclear staining, right? So this is kind of what you'd expect to see. Not every cell is positive. Some of them are completely negative, but any significant nuclear expression here in any of the tumor for beta-catenin is strongly suggestive that that's what this is. So here's a resection. And this was set, so this was called low-grade biphasic salivary neoplasm, you know, whatever, favor basal cell adenoma. And they still did a frozen, which eventually was useless because it was the same diagnosis that we suggested on core. But here, you know, so when you see salivary neoplasms for frozen, I'm trying to get them to stop doing them unless the differential is adenoid cystic, right? In this case, they did it anyway. But when you're on there and you're working with your attendings, right, the only thing they want to know is it low grade or high grade, right? And or if it's like, if you think it's adenoid cystic, if it's like high grade transformation of adenoid cystic, right? So you are able to tell all of that on frozen. You do not need to give a definitive diagnosis. All you have to say is low grade or high grade. Because if it's high grade, they'll do a neck dissection. If it's low grade, they won't. So remember that sometimes freezing can artifactually distort, right, your morphology. And you can get wrinkling and sort of abnormalities of the nuclei, but things that you always want to look for, right, are prominent nucleoli, infiltrative border, necrosis, mitoses. And if you don't see prominent nucleoli, increased mitoses, necrosis, significantly infiltrative border, right, then you're pretty much dealing with something low grade. So these are wrinkly, right, they're wrinkly, but they don't have prominent nucleoli, they don't have mitoses, they don't have necrosis, so low grade. And this is the resection, yeah.
What's the morbidity for a neck dissection? I actually don't know.
So it's, the procedure itself is not the issue. It's more of the post-procedural edema,
Yeah,
facial edema
oh, okay,
due to lack of, I mean, kind of like with
Yeah.
armpit, right? So it's mostly facial swelling.
facial edema, okay,
Also, once you've gone into the neck once, reoperation is challenging. So reoperative neck, because it's such a tight area and it scars, right? And so people are like, I only want to go into the neck once, right?
Yeah.
Hence the apprehension. So the thing with basal cell, right? Basal cell adenoma, circumscribed, recapitulates that morphology that we saw on the biopsy with really nice, really pink eosinophilic basement membrane globules, right? So those are the globules we were seeing on the core biopsy that show up even brighter. That pink stuff is basement membrane material, right? Because the basal cells, right, secrete basement membrane material, and so you often see the hyaline globules or bands, and even better now, right, we see that spindled stroma in between the epimyelin islands. So this is the stuff, right, that was staining for S100. So this is classic basal cell adenoma. Okay, here's a different case that had a similar differential diagnosis on, FNA or core biopsy. Basaloid neoplasm, I think, was the FNA, and sent for frozen. So I'm going to direct you to this area over here. So what does this have that already? Invasion, right? So it's carcinoma. It has invasion, this nice tongue and islands of tumors separated by completely normal. So invasion. Okay. Also,
high grade,
pardon?
but higher grade.
Yeah, looks very hyaline stromal bands separating these islands. So the two features that are the same, right, are these hyaline globules and these hyaline bands around the islands. That is textbook, right? Textbook basal cell neoplasm, right? So the only way you know that this is a basal cell adenocarcinoma is invasion, right? But otherwise, the epithelial and myoepithelial islands with hyaline bands are exactly the same. So the pitfall here is that one may interpret these spaces as cribiform. And so this was actually called adenoid cystic on frozen. Okay, but we know better. It's not. It's a basal cell neoplasm. The cribiform spaces in adenoid cystic, the secretion is more bluish. It's more connective tissue mucin, right? So if you compare, I'm happy to send out this link, so you can look at these on your own for the path presenter, right? The mucin in adenoid cystic is bluish. The material in basal cell adenoma is basement membrane, so it's really pink, right? So, and you might read about how in basal cell neoplasms, it's like a jigsaw puzzle, right? So it's these pieces that fit and interconnect with each other like puzzle pieces. That's also really characteristic of basal cell neoplasm. So yes, this is a basal cell adenocarcinoma. And here's more of the permanent sections. Again, confirming that kind of infiltrative border and morphology. So yeah, here it's sort of trickling, right? It's trickling out into the septum between the normal salivary, but still cytologically bland, no mitoses or necrosis, so low grade basal cell adenocarcinoma. This is a rare these are rare diagnoses. I think basal cell adenoma, more common than basal cell adenocarcinoma, but they exist, and that's what they look like.
Would they not do a neck dissection for the adenocarcinoma if it's still low grade?
So low grade BC adenocarcinoma, they would not do a neck dissection. I would have to check back on this patient because it was called adenoid cystic on frozen to see what they did. In fact, I will do that because I don't remember. But no, if you call it low grade carcinoma, non-adenoid cystic, they will not.
Okay,
They should not do a neck dissection.
so I know cystic is like the sole exception.
Exactly. Okay, and, yep, stains again. P 40, P 63. That must be, yeah, that must be C-kit, right? So similar pattern. And right, don't forget that C-kit stains membrane of your background cells. And this has to be, oh yeah, this has to be beta-catenin, right? So beta-catenin is strongly membranous in epithelial cells. And in fact, in this case, beta-catenin is only membranous, right? Without nuclear and without cytoplasmic. So that fits with our knowledge of the lack of beta-catenin mutations in basal cell adenocarcinomas, right? So all of it fit. Okay. I don't know why this is here, but this is an example of epithelial myoepithelial carcinoma. Okay. All right, we already kind of went through this chart. All right, it's 8:59. You want me to stop? Because there's a lot more on here. I don't really necessarily need to go. I can go through the next time, or we can switch gears. So, do you guys have a preference? Let's see how much is left here. Do you guys have a preference for next lectures? Do you want me to continue on doing more unknowns for salivary? Do you want me to switch to doing like a thyroid didactic? What do you want?
Yeah, I like that.
Unknowns. Okay, salivary, continue on the salivary theme. Okay, I'll give you guys salivary unknowns, and then we can decide if you want to pivot to something else, because I think we probably don't need to do entirely salivary, unless you want to, we can, but we haven't heard from thyroid in a while, I think, either, so we'll play it by ear, but next time I'll give you salivary unknowns for Monday. I'm on Monday, right? Yep, okay, all right, cool, I'll get those out later today. Thanks. Thank you.